We'd like to invite our speakers back downstairs for a panel discussion. So if we can have our two patient speakers as well as Denise, Dr. Snow, and if Dr. Bresden could also come down, we'd like to welcome them all to the panel. Yeah. And Leanne. All right, so I'd like to open the discussion to you guys, first of all, and see if anyone else has any questions for the speakers up here.
Hi, everybody. Dietitian, I am your biggest challenge. A total gastrectomy patient, 16 years, and my diet is consistently changing. So I used to be able to eat tomatoes. A year ago, it gives dumping, serious dumping. It's a big challenge for me to go through it, but once you get past that 5-year mark of survival, there's no help. I'm from British Columbia. It might be a little different, but my doctor retired, but even still, they are not experienced with a person with me, so I'm kind of left in limbo. And I mentor other people, like globally, and that is apparently one of the biggest challenges of a lot of them that I'm mentoring, that there's no follow-up as those of us with no stomach go through, and I'm especially different because I have no gallbladder, and I have a pouch. I will give my speech later. So what you were talking about, I cannot do the high fiber. It's out. And you mentioned at the end that everybody is different, and I am way beyond the different. But I just wish there was a dietitian available for those of us that are long survivors. I know I'm rare, but it really would help a lot because I really need help on that. Thank you.
I think you bring up a very important point. Is this working? A very important point about access to nutrition care, and I think it's an issue before treatment, during treatment, and then after treatment as well, having that access. And it's something that's being increasingly recognized as an important need. So we're going to get there. In terms of long-term access to a dietitian, not everyone may have access to insurance coverage for a dietitian, but through the Dietitians of Canada, you can actually search for dietitians in your community based on postal code and also based on their area of expertise. And so that might increase access for some people who are no longer being followed in a hospital setting.
Any other questions?
I have a question for Dr. Snow about immunotherapy for metastatic disease. Do you see the future as potentially rendering metastatic disease resectable, or do you think that it's heading towards long-term control through immunotherapy?
That's a great question. As I mentioned, immunotherapy is now well established in a number of other cancers, and what we're finding is that for each and every cancer, it has a different face. Melanoma is certainly the most successful. There is actually the ability to cure people with stage 4 disease, as in long-term disease is gone forever. What we generally see is that for those people who do respond, they have prolonged responses, but they will relapse. And so for those patients, it may very well get us to a point where they could become resectable. And it's leading us to really think outside the box in many ways in other cancers that we had generally never thought outside the box or ever thought about getting to that point of being able to do things like high-intensity SBRT radiation or surgical approaches. The nice thing that we do see, especially in those patients that we're treating in the neoadjuvant setting, so while their tumor is still intact, we've seen those pictures in the colon cancers, we're also seeing this in lung cancer. When you give the treatment and the cancer is there are so many antigens, which are those proteins that the immune system responds to, that a very small amount of treatment can lead to a very huge response. Usually, if we're giving it in the adjuvant setting, we're targeting micrometastatic disease, so maybe 1 or 2 cells that are hiding, so you don't have that large antigen burden to stimulate the immune system. So I think that we're going to see more and more of these treatments moving to the preoperative setting. We're certainly seeing that happening in lung cancer and head and neck cancer now. And for a disease like stomach cancer, I think that it's really going to lead to a lot more referrals for you guys. And we talked earlier about HIPAC and how there's very specific group that we would who've had an amazing response to chemotherapy. If we get the right patients with immunotherapy and find different techniques that we can get more responders, I think we will see a lot more long-term survivors where immunotherapy was part of the management.
One question that we also get a lot, and on this panel, actually, we have two medical oncologists. So Dr. Bresden is from St. Michael's Hospital right here in Toronto, and then Dr. Stephanie Snow is from Halifax. So one question that we get a lot is in terms of access to clinical trials. So if I'm a patient in Ontario and I see a clinical trial in, say, Halifax, how would that work for me as a patient? Am I able to access that at all?
I could take that question if you want, because Christine's lucky she works in a city with a lot of different centers, so it's one thing for her to refer to Princess Margaret a couple of blocks over. I have a lot of patients, especially when we've been through all our standard treatments in Nova Scotia, who ask about clinical research trials, and we are a trial center in Nova Scotia at Dalhousie, but based on the volume of my population, I can't open a lot of these very rare specific subset trials because we just can't fill them up, and it's a lot of work and money to open up trials. So what we do is we have a pretty small network. And for instance, if I know that somebody's MSI high, I reach out to my colleagues and say, who has a trial open? The problem is, even if you find the trial, it may not be easy to access from a logistical perspective, because our province will only pay for medical therapies that are already established but not available in the province. So if I don't have a surgeon to do a stomach cancer, I can refer to a surgeon in Toronto, because it's an established treatment. But they won't pay for things like transportation or lodging, those types of things, for a patient to travel for an experimental treatment on a trial. Sometimes we're lucky that someone has a sister that lives in Toronto or that type of thing, but usually patients are going to have to pay for their accommodations and their travel. And depending on what the trial is, they may actually need the patient to relocate to that area. That's especially the case for phase 1 trials, where it's very early in the experimentation with a new molecule. They need you actually within a certain radius in case you get sick in the middle of the night. You need to come back to that trials group. So there are barriers from that perspective. What we try to do is know what's going on so we can specifically find those patients, but it can be tough if you don't live in one of the big centers.
Thank you. And then one more question that we got actually for our patient speakers here. So healthcare providers, they always contact us and they say, how can I make my practice better? What can I do for gastric cancer patients that will make me stand out? What is a piece of advice that you can offer a healthcare professional? How could they have made your journey better? Yeah, the patients. Patient speakers. Leanne and Maddie, please.
I think, well, for my case, again, it was unique because I think I'm the only one in the Northwest Territories who survived stomach cancer because it was caught so early. I know that I did speak to my gastroenterologist about it, and when we talked about how much of a fluke it was that my cancer was even caught so early, was that I basically kind of called him out on the fact that why did it take so long for my colonoscopy to even get booked? And again, like I said, it was the surgeons who had kind of brushed it off because my age, lack of symptoms, it wasn't done. And it wasn't until another visiting gastroenterologist came and did it. But I think even he said he kind of did it as a professional courtesy just because he wanted to rule out that something was wrong with me. So when I did speak to my regular gastroenterologist, he said, if we suspected cancer in everyone, then we'd be performing scopes on everyone, and it's not feasible. So he didn't really have an answer for me, and I basically said, so then I could have just been that one-off who didn't get the scope, and then 2 years later, where would I have been? And he said, well, we're not going to talk about that now. So I think the thing for me was that I advocated a lot, and I didn't say this in my presentation, was that, but I did allude to it. I said I had fought for 18 months just to even get the scope in the first place. And so when I think about my experience doing that, and I think the fact that I'm a nurse also helped me get through the process easier because I knew how it worked. I don't know what to say for all of the patients and the family members who are advocating for them who don't have the resources that I did, other than just the patients kind of have to advocate for themselves, especially in the north, and that's really sad. So I don't know what to say, like how to answer that question, other than maybe listen to your patients a little bit more. Like, just because they see something on the news and they think they have stomach cancer or any kind of cancer doesn't necessarily mean that their worry shouldn't be there. And then just as an extreme example, there's a patient that in the clinic that I worked in, she had this rare brain tumor. And then because she was diagnosed at some kind of sports meet, every single person on her team, the parents came and wanted their children seen because they were worried about brain tumors. And so then they kind of bring that experience to the discussions about, are we doing too many tests on people? So I think there's the fear aspect that needs to be taken in consideration, but then again, I don't think every single person that walks into a clinic needs to get scoped.
Thank you. Sorry? Yeah, of course, Dr. Bresden.
So navigating the system is extremely challenging, especially with the diagnosis of cancer. And I think what is moving forward across most provinces, I can speak for Cancer Care Ontario, within Ontario, are these patient navigators. And navigation, so recognizing that there are many players in a diagnosis of cancer. We know that the surgeons are involved, gastroenterologists, for example, the first site where this cancer is diagnosed, radiation oncologists, medical oncologists, dietitians, social workers. So it's a whole team that takes care of our cancer patients, and specifically with gastric cancer. So I think moving forward, we really have to push the government more to have patient navigators to help all patients with cancer to understand the disease and to navigate through the system. That's just my plug, is to get more navigators.
And I can't agree more. We have a full system of cancer navigators, one per county in Nova Scotia, and they're completely invaluable. Most of them are nurses who come from the cancer center, and they just make sure that things get done and it happens in a timely manner, but also providing all those other supports. They are absolutely invaluable for providing the care for our cancer patients.
That's amazing. There are a couple of questions online. I know that there are a lot of hungry faces here, so we'll take a couple.
Sure. So this comes from someone, they were saying, given their family history, so their paternal grandmother, paternal aunt, and father has intestinal metaplasia, and their daughter has diffuse gastric cancer. So they're asking, when you do genetic testing, what percentage do the hereditary genes express themselves? And is it advisable to do genetic testing for their siblings and children?
We will have a geneticist
Later.
coming into
Okay.
a further panel, but if anyone would like to weigh in now.
So when I refer my patients for genetic counseling, it's just that. It's not genetic testing, it's counseling. So the family history like that, I think it's very reasonable to have that discussion. And those are exactly the conversations that we'll probably hear about later. What is the chance that we can find a gene, and what are the implications of finding that gene? And so I think that if there is a question, going for the counseling to talk to an expert is definitely the best way to go.
Can I do?
One more, yeah.
So this actually is for Denise. This patient says she's had a partial gastrectomy, but now she's heading to have the remainder of her stomach removed. She struggles with getting enough fluid, and she has trouble with feeling too full, and she doesn't want to drink anything, essentially. Do you have any tips for getting more fluid as well as good nutrition in, because she's worried if she drinks too much fluid, she doesn't have space for actual food?
I think then it's important to choose fluids that are going to offer lots of calories and protein. So then you get kind of two birds with one stone. As long as you're, not having issues with dumping. But even then, there are commercial supplements that have lower sugar content that might be well tolerated that could still have calories and protein. You can do homemade smoothies as well, and that can help to get in the fluid while again controlling the sugar intake of that as well. People do often mention, and we have no literature on it, but for some reason people have a really tough time with water, plain water. They just can't get it down, or it causes stomach pain or gut pain. Just from kind of hearing from patients, often fluids are better tolerated when they have some sort of flavor to them, or even I've had some people who have had better luck with adding lemon to the water. And I'm not sure what the mechanisms of that is, but it helps. And then the other thing is experimenting with temperature. So some people might find room temperature fluids easier to tolerate, or warm fluids easier to tolerate than cold fluids.
Okay, one more, or we can save it for the next panel then. Okay, great. So I just wanted to say thank you so much for all our speakers and our panelists, and we're ready for lunch, guys.